Welcome. My name is Robin Young. I'm the publisher of Orthopedics This Week, sponsor of the annual Spine Technology Awards. I'm delighted to present one of our truly best spine masterclasses yet. In just 30 minutes, the master faculty will review both primary and revision cases using a new, highly innovative implant with an absolutely zero profile and exceptional versatility. The implant is Sabre C, and it comes from a young company named Elevation Spine. Starting our program off is Dr. Andrew Fox. He's a board-certified neurosurgeon who serves as director of spinal surgery at Sutter of Sacramento and is a faculty member at UC Davis. Following Dr. Fox is Dr. Samuel Joseph, a board-certified spine surgeon who runs the internationally renowned Joseph Spine Institute in Tampa Bay, Florida. So thank you to our sponsor, Elevation Spine, and our faculty for what I think you will find is one of our best spine masterclasses yet. Dr. Fox, the program is yours.
Good evening, everybody, and thank you for joining us to learn about Sabre C, one of the new elite spine products out for cervical fusion. As we know, cervical fusions have a long history and challenges. They've been performed since the early 1900s with many devices and iterations over time, sometimes with mixed results. We saw early on, we tried doing cervical fusions with just bone alone. Then we went on to our plating systems with screws. Then we started developing the cages, and soon we got into the new areas involving cervical standalone cages. As we know, the cervical surgery, the ACDF, has been around. It's been a successful operation. It's got a greater than 93% success rate. High volume of cases, about 308,000 performed in 2021 alone. One of my favorite operations for myself that usually has good outcomes for our patients. One of the early procedures was the anterior plating. It's got the longest history of use. Issues with it was difficult to access, hard to reach levels. For example, a C2-3, a C3-4, a C6-7. Close proximity to the esophagus can cause dysphagia or dysphonia, can irritate and exacerbate adjacent level problems, can experience hardware fatigue, and revisions can be quite complicated. We then went on to the standalone screw-based technology with many options. And what was great about this was it was a zero profile. So we had no anterior hardware. It utilizes the familiar screw technique. However, having to put in the screws, we had steep angles to deal with. We had limitations, particularly at C7T1 or at C23, and there was lower reimbursement than the anterior plating code. Ultimately, we went along with standalone inline fixation. And what was great about this is still provided us with zero profile, no anterior hardware. Fixation was delivered in line so we could avoid dealing with steep angles. And some of the designs incorporate a plate with a cage. However, it's less familiar than screw fixation. Here's a couple examples of some difficult issues that we come across. On the left in the upper C-spine, we see the C2-3 fusion that occurred. And then at the image to the right, we have to deal with the C6-7 level and a long plating system as well. What are some other issues that we dealt with? Screw breakage. You can see the mid shaft of the screw fractured on that image. To the left, a screw backing out, or just simply causing dysphagia and causing irritation to the esophagus due to the anterior plate. Other things that occur, adjacent level irritation, where the plate may ride high, causing osteophyte formation at the level above, or cage subsidence. What are some of the issues that we deal with? Well, the procedure, lengthy steps, hard to use devices and instruments, return of symptoms occasionally, non-unions, and complicated revision options. These are some of the difficult cases that I had to endure and learn how to deal with till I was able to use Sabre C. This is one case. The gentleman that presented to my office, 57-year-old, prior neck surgery, had tingling and numbness in his hands for 2 years, had done well with his initial surgery, but his symptoms now returned They became new and worse. He had good strength. His range of motion was still limited, but he did have some signs of myelopathy. His MRI revealed stenosis adjacent to his prior fusion. He had some myelomalacia where he had his prior surgery as well. The axial image, we could see the indentation against the spinal cord at the C3-4 area. What we did, I'll show you later. Another case I had issues with, 64-year-old female, left-hand weakness. She was dropping things, had neck stiffness. Her balance was off. She was using a walker. She also underwent a prior C4 to 6 ACDF 20 years ago, failed all conservative care. Her BMI was 51, which already posed an issue with thinking about doing it in a surgery center. So we encouraged her to lose some weight, but ultimately it really wouldn't have mattered for her stenosis. We looked at her MRI, and she developed adjacent level disease above and below her prior fusions at C3-4 as well as at C6-7. As you can see, she has some myelomalacia as well at the C6-7 area. Additional images. Once again, we'll show you what we did later. This was probably one of the most challenging cases we had because of her morbid obesity, her body habitus, and the fact that it was at two high levels, one high level, one low level that was difficult to reach. Our last case was a 50-year-old mechanic who had left upper extremity weakness, neck pain, radiated to his arm on the left, difficulty lifting his arm over his head. He failed conservative care. We were trying to get approval for a 2-level disc arthroplasty. However, he kept getting denied, and he showed up in the ER because he was getting progressively weak. His MRI revealed significant disc herniation at C4-5 with compression of the cord as well as a nerve root, and moderate foraminal narrowing as well at C5-6. We took him in for surgery. We were able to place the disc arthroplasty. However, we had difficulty visualizing the C5-6 level. I didn't feel comfortable doing the disc arthroplasty there because I couldn't visualize it completely intraoperatively. So we ended up putting a competitive product, which was available at the time. Sabre-C was not around at that time, to be able to help stabilize the spine. Patient underwent surgery, no complication. Post-operatively, he's done well. His symptoms have all resolved. His quality of life's improved. He's back to working as a mechanic with no issues. So what are things we need to think about? We need clear surgical solutions. What we need are streamline the device implantation rather than working at angles, facilitate installation in tight spaces, and ensure stability of the fusion device. Next, I'm going to introduce my friend and colleague, Dr. Joseph, to speak to you about Sabre-C.
Thank you, Dr. Fox, for the introduction. We'll move forward with talking about more about elevation spine and the Sabre-C construct. These are the indications for the Sabre-C. It's a cervical interbody fusion device. It's intended for skeletal mature patients, degenerative disc disease, from cervical 2 to thoracic 1. This sort of goes over a lot of the indications that it has, along with something like an anterior cervical fusion, and any of the other indications for the standard traditional plate and screw with cage technology. This is an overview of the implant. You can see it's a nice melding of titanium along with an anterior locking plate, as well as what's called fixation spikes. Along with the titanium surface, there's also a good graft window that allows for a good amount of bone to be placed, allograft of your choice, to be able to be placed in that location and mounted into place, so you get both a graft window as well as a onlay system with the titanium plate and the surface technology on that as well. Other features that I really like about it is the zero profile cervical plate. It doesn't stick out past the implant in regards to irritation with the esophagus or any other anterior structures, as well as the anti-rotation teeth. Once they're seated into the vertebrae, they help stabilize the implant while you're putting the fixation spikes in. So far, there's been about 400 implants done, with the initial one being in August of 2019. Here are some of the novel features, which I've already talked about, but here's a good illustration of those. The spikes are already preloaded. The spikes are then attached to the cage. The cage is then mounted into place. And then those spikes are deployed simultaneously in a one-step inline approach that allows a good angle without having to pull and push cephalad or caudal. Gives you right in line with your dissection and with your access, which allows you to access hard to reach places such as C23 and C71, but also allows the standard levels to be done with a lot easier dissection and a lot easier access. The zero profile cervical plate has been cleared as an anterior cervical plate, which from a surgeon's technology, standpoint, it allows us to be able to both code and bill for anterior cervical fusion, as well as it gives us a good construct that helps as a plate to allow for those fixation spikes to be implanted securely and to prevent them from backing out. So some of the versatility that the system has, it's either spikes or screws. Spikes are the ones that are used the most commonly because it's done in more an inline technique, and I think separates this device from all the other ones that are standalone. You also have the benefit of a cervical plate to give you added stability to the spikes that you're implanting. You also get two footprints, one from 12 by 15 and one that's 14 by 17. So both of those implants gives you a little bit more versatility and able to deal with larger patients as well as small patients. And with the spikes that go cephalad and caudal, you don't have to worry necessarily about the length of the screws you get. You got to make sure that the cage is in the appropriate position. The heights that you get are 5 to 9 millimeters. You have a good amount of lordosis with 6 degrees, which I believe is industry standard. And this allows us to be very versatile and be able to adjust our implants to the disc space that we're operating. So this is an animation showing how the spikes are already preloaded and then inserted into the inserter. That's the depth gauge. And what that is, you get to incrementally change it for how much inside you want, how much depth you want it to be inside the vertebral body. The cage is then inserted and attached to the inserter. The whole construct is then implanted, mounted into place. And through that same system, that as you implant the cage, the deployment technique for the spikes is placed through and mounted into place to lock the spikes into position. You can see that the plate is then the next step in order to lock this into position. There's an inserter for the plate. The plate is then secured onto both sides, both laterally, and then secured to see that it's flat and flush with the cage. This is the first case. This is a 55-year-old female who had an ACDF from C4 to C6 approximately 8 months ago. She has significant pain radiating from shoulders and trapezius. She had a herniation, you can see on the MRI, with severe disc space collapse at C3-4 that developed pretty quickly. And so at this point, she was young, she was active, and she already had swallowing issues, vocal cord issues that I didn't want to make worse. And so the beauty of this device is that I can fix her problem without having to remove her prior instrumentation and get it placed in a good position with good disc space distraction. So you can see this is the post-op x-rays of C3-4. Patient was discharged the same day. The headaches improved, neck pain was improved, and she had no more ridiculous. And I think this implant, you can see, is wide enough. It covers enough disc space, and the spikes are implanted in a position where it doesn't affect the prior instrumentation, and that's part of the versatility. And again, good disc space distraction. It's an atraumatic exposure. I didn't have to expose the rest of her instrumentation, and I can use big footprint. This is a second case. This is kind of an interesting case. This is a 65-year-old female. She had some mild neck pain, but her biggest issue really was arm pain. She had a lot of pain that radiated into both arms as well as down to the fingers. Some could argue she needed a 4-level ACDF, but for someone who has minimal neck pain and with symptoms that correlated very well with the herniations at 5, 6, and 6, 7, I thought she'd be an excellent candidate for the Sabre-C in case we did need to come back for adjacent level disease. And this also with the zero profile plate gave us the best chance of not violating the other disc spaces above and below. So you can see we got good distraction in the disc spaces at 5, 6, and 6, 7. We did not address the other disc issues that she had, which we didn't need to. She went home same day, as well as that her radicular symptoms had resolved completely. So some of the take-home points, you can do multiple levels with this procedure. It spares the adjacent level exposure to try to not allow it to degenerate any faster than it's going to. And again, good disc space distraction. Here's my third case. This is a 67-year-old female, prior cervical fusion, C4-6. She had worsening neck pain, arm pain, problems with coordination, headache, spasm. Looking at the x-rays, you can see she had significant degeneration above and below, as well as she had a screw that seemed to be backing out a little bit at C6 with a myelomalacia evident on the MRI that was becoming symptomatic. My concern was that she was having some pseudoarthrosis with continued motion at that level, resulting in hypertrophy of her ligaments posteriorly. So she needed a front back surgery. And I think with a system like Sabre-C, this was the perfect indication where I can take care of the disc spaces above and below the prior surgery, as well as be able to flip the patient and deal with the posterior issues. So you can see here, this was the first part where we got good disc space distraction, was able to put an implant above and below. And I think this also talks to the versatility of the implant where you can flip it, where one spike can be cephalad and 2 spikes caudal, as opposed to the normal technique where it's 1 spike caudal and 2 spikes cephalad. So it really shows the versatility of this, where you can put it between the prior instrumentation and not have to worry about the spikes impinging on the prior instrumentation. The patient was then flipped, a laminectomy was performed, and screws replaced posteriorly to augment the big bony removal. Patient's neurological symptoms improved, as well as headaches. Some of the take-home points for this, I didn't need to revise the prior instrumentation, as well as the versatility of being able to put the implant with the 1 spike cephalad or the 1 spike caudal. That ends my review of the cases. I'm going to give it back to Dr. Fox.
Thank you, Dr. Joseph. So now getting back to some of the successful cases we've had with Sabre-C. Earlier, I presented this case of a gentleman that had a C4-6 fusion and developed adjacent level stenosis at C3-4 and signs of myelopathy. Well, ultimately, I ended up treating him with a Sabre-C. He underwent the surgery without any complications. Within 2 weeks, no pain medications, significant improvement, no dysphagia, no hoarseness of voice. He did well with physical therapy and ultimately returned to work full duty within 5 weeks. The key for me in this case was the ability to access the C3-4 area with the minimal incision, minimal retraction, and work in line. I didn't have to take down his prior plate. We were able to complete the surgery without trying to get angulation at the C3-4 with a screw-based system. This is what his films looked at later. Patient doing well, no issues. As I mentioned earlier, at 10 months, he had been to all normal activities without any complaints and no complaints of any neck pain. The other case that we looked at earlier was a patient that underwent a prior C4 to 6 ACDF and developed stenosis above and below at C3-4 as well as at C6-7. She was dropping objects, unable to lay flat. And ultimately, the treatment she underwent was a Sabre-C at C3-4 as well as C6-7. At 2 weeks, she had a little bit of dysphagia. Her upper extremity strength had improved. Her grip was still weak, but getting better. 6 weeks, her pain had resolved, and she started focusing on her lower back issues. With flexion extension films, we saw the hardware to be intact. Things were stable, patient was happy, and she was doing well. Ultimately, at 4 months, she developed a little bit of neck pain, and we ended up ordering a CAT scan to assess her fusion. This is a sagittal image with axial cuts. And ultimately, when we looked at the imaging on both the sagittal and axial views, she appeared to be fused. We recommended more physical therapy, and her symptoms ultimately abated. At 11 months, she had minimal neck pain, was back to working multiple jobs, regained the strength in her arm, as well as her grip, had no tingling, and overall was very happy. This is my last case that I wanted to present. This was a typical LA patient that sought about 8 opinions, came to my office complaining of significant neck pain, pain in her right upper extremity, been going on for 2 years. She was dropping objects. She tried every treatment you could try: nerve blocks, epidurals, TENS units, chiropractor, pain, activity modifications, pain management, yoga. And finally, she was deciding on undergoing surgery. She had her MRI, which revealed stenosis at 5.6 and 6.7. It was indenting the cord. She had foraminal narrowing as well, and significant neck pain, as I mentioned earlier. She underwent a 2-level ACDF using the Sabre C. However, in this reiteration, I ended up using screws rather than blades. 2-week mark, she had no dysphagia. The pain on the left, she had a slight pain in the left scapula. She started physical therapy. However, her grip strength improved significantly. At 4 weeks, she had a little bit of neck spasms. We restarted her a muscle relaxer. Then ultimately, at 3 months, she was doing well. She had no tingling, no numbness. She was back to normal activities and happy with her postoperative result. We obtained the flexion extension films. It showed no sign of any instability, and the hardware maintaining.
Doctors, actually, I have a question for both of you. And Dr. Joseph, if you don't mind, if you'll take the first one.
Sure.
Why did you choose to use Sabre C the first time?
Well, I think there's been a big lack in standalone devices that are secure enough, as well as allow for fixation without severe dissection. Some of these standalones that I've used have really big angles, being able to place their screws in order to anchor into the top vertebrae or the lower vertebrae. This inline technique was ideal, and it was very intriguing, as well as the zero profile. I think the versatility of it, all those things caught my attention, and so far it's been very successful.
Dr. Fox, same question to you.
I think when I looked at that product, it was a very unique product, allowed me to do that inline technology, where a lot of times you have the struggle at the higher levels, and it eliminated that angulation to put in the screws. Also, I looked at the system. It really was unique. It had 7-point fixation between the blades and the little teeth that are on the anterior plate. And it was very slick. You could put all the blades in at once. You didn't have, it saved steps. And I thought this would increase in safety, as you're not passing as many instruments in during the surgery. You can do the surgery through even a smaller incision. And I think it's just better for the patients overall.
And I noticed on a lot of your x-rays, you were putting it in alongside other hardware, and it seemed that low profile really helped you, that versatility helped you in those kind of cases.
Absolutely. I mean, we're still providing patients the zero profile technology, which is superior now instead of the plating system. And you're giving them also the safety aspect of not having to try to put the screws through the angle devices. So I think those two things are important. At the same time, you're accomplishing the goal that you want to accomplish, which is fusing the patient through the typical anterior cervical discectomy approach.
And now I have a second question. I'll start off with you, Dr. Fox. Why is, now that you've had a chance to use it, why has Sabre C turned out to be your go-to device for the ACDF solution?
Well, this is probably the only standalone device on the market that really gives the flexibility, many options to surgeons. You've got the anterior plate that attaches to the cage, and there's options of peak tie coated titanium as well as bone that's being developed. It was FDA approved for that. You have the options of doing blades or screws. You have the standalone technology, and the blades, you have the option of putting in all three blades at once or one at a time. So it really gives the most amount of diversity to the surgeons to accomplish the goal that they need to accomplish and still providing the best safety for the patients.
And then same question to you, Dr. Joseph. Why Saber C has become, now that you've used it for a while, why has it become a go-to device for you with the ACDF indication?
I've had a lot of success with it in the patients that I've used. I think that the graft window allows me to place bone graft that I use normally in my cervical fusions. I like titanium cages as opposed to PEEK cages. I think that technology is superior. And I think being able to place everything in line, in my anecdotal experience, I've had less issues with vocal cord issues as well as swallowing.
And I have to say, as I saw your cases, it was so interesting how you were able to use it with the existing implants, either above or below. And it just seemed to be able to, again, that lower profile, zero profile, seemed to be the key to those cases. Is that accurate, do you think?
Yeah, I do a lot of revision surgery in my practice, and it's been a very versatile tool for me to be able to use it. But then again, even virgin cases with 1 or 2 level cervical fusions, it's still my go-to, and I think it reduces the risk of adjacent level disease, and it reduces the amount of dissection.
And you've got that versatility. So no matter what situation you're confronting, you can adjust.
That's correct.
Wonderful. Really good. Thank you, Dr. Joseph. That was just really great. Let's see what questions we have from our audience, and I can see they're coming in. Looks pretty good. That's the magic of pre-recording. And incidentally, I just got a note that Dr. Joseph was called away. I don't know if he was on call tonight or whatever. But I do have there's one of our attendees is asking, how is Saber C removed? Dr. Fox, how do you remove it if you need to?
It's a great question. So the little anterior plate that goes over the blades is easily removed with a simple instrument. You can use a coker to remove it. However, the blades themselves have an instrument that will thread into it, secure it, and then essentially you rotate your hand to the opposite direction to have the blade pull out.
I have seen probably 24 different cervical plates over the years, and this is the one plate that just looks so unique to me and so interesting. How's it, now that you've used it for a while, really, how have you incorporated Saber C into your practice, and has it changed your approach to how you previously did ACDF?
I mean, the approach to the surgery is the same. However, what's unique about the implant, as we talked about earlier, is the 7-point fixation going in and the inline technology. A lot of the other technologies, you got to put the screws in at an angle and tilt your hand. It may be difficult. Versus this, once you get the cage in, the blades deploy through that same trajectory. So you're not having to switch your hand out, do multiple passes, which puts it more risk for injuring the esophagus or other structures in the neck. And you can put all 3 blades in at once or do one at a time, but either way, it's inline technology. And that's something that's unique to the product.
And how does it compare to other standalones in the OR in terms of anesthesia, procedure time, procedural flow?
Yeah, the flow is faster because once you get the cage is attached with a cartridge that has the blades in it. So once you put it all in, you can deploy all 3 blades essentially at once. So it saves time, will reduce anesthesia time, as well as safety. So you're not passing instruments back and forth while you're doing the surgery.
And just in terms of implanting the Saber C itself, how quick is that?
I believe once you get it in, it'll probably take maybe 10 to 15 seconds.
Oh, geez. Not bad. Not bad. Now,
Not bad.
Not at all. So most people think of the anterior cervical plate as a traditional long flat plate implanted on the anterior aspect. Saber C, it's FDA cleared, also FDA cleared as an anterior cervical plate. How is the Saber C anterior cervical plate different from the other guys?
Well, what's unique about it is you have the cage that attaches to the plate on the back end table where the scrub tech can do it. And the plate was independently tested as a standalone plate itself. And that's unique as well to the product. So when you attach it to the cage, it gives it the plate structure, which bands essentially the vertebrae above and below. it has 4 little teeth on that anterior plate, and that spans it. So that's considered really a plate, but it gives it the standalone technology where it's zero profile.
Spikes versus screws. Why would you use one versus the other? And what's the advantage of having both options in the system?
Well, when the product was designed, it was designed with everybody in mind, meaning some people may like spikes, some may screws, some want the lag factor, some are okay with just having the blades alone. So it gives versatility to the product. The product is one of the most versatile standalones out there, where it gives the surgeons the most amount of options. The screws obviously take a little bit longer to put in, as you'd have to put one in at a time, versus the blades, you can put all 3 at a time. But a lot of it's surgeon preference.
So I'm going to, we've got AAOS coming up in a couple of weeks, and I think everyone's getting back to meetings. I know I'm going to be going down to the Cabo meeting and the Castelvi meeting, and everyone's getting back to talking to each other. I know I'm going to be talking to a lot of people about the Saber C, because honestly, I love this product. I really do. And in your opinion, and this is my final question, looking at future procedures, how could you foresee this technology being used in the spine in kind of a broader sense?
Well, it's really something that, as I mentioned earlier, it gives surgeon versatility. It really gives you the most amount of options. So if you have someone who's got a prior fusion from C4 to C6 and they've got adjacent level issues, you can go ahead and do the C3-4 and C6-7 without having to remove the plate, or without dealing with the other issues that we used to deal with. And you're in hard to reach places. The C3-4 is difficult, as well as the C2-3, and C6-7 can be difficult, particularly in patients who have stout necks. So this gives the surgeons that ability to be able to put in the cervical fusion and that inline technology for difficult cases. Of course, it's easy to put it in easy cases, but it gives you the whole spectrum to be able to treat cervical spine disease.
And I'll close with this simple observation, which we'll probably edit out on the final production. But my son just had cervical spine fusion surgery, and they did the plate and the rods in the back. I really wish that I had a chance to educate his surgeon about the Saber C. I think it would have made a difference in his recovery. He's doing fine. But this is truly one of the best designed new products I've seen in a while. And Dr. Fox, I appreciate you and Dr. Joseph taking the time and really going through these cases with us. It was really outstanding. And with that, I'm going to thank everybody for attending, and you especially, Dr. Fox and Dr. Joseph, for taking the time and explaining this really interesting product. Thank you.
Thank you.